This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar. Good afternoon, and thank you for joining us today for our HealthyU webinar series on advanced treatment for prostate cancer. My name is Christine Santini. I'm the Director of Marketing Communications at Mather Hospital. At any time during the presentation, feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. This webinar will be recorded and made available on our website at matherhospital.org/healthyu. That's the letter U. I'd like to introduce you to today's presenter, Dr. Joseph Cerrone. Dr. Cerrone is the Director of Precision Cyberknife of New York, using state-of-the-art radiosurgery for his patients at New York Cancer and Blood Specialists and Mather Hospital. He first became interested in the radiation oncology field for the challenge of mastering a single modality to treat patients and for its multidisciplinary approach towards cancer treatment. During his radiation oncology training, he learned how to treat all types of cancer and has treated many difficult cases. Radiation oncology has been used in many areas to eradicate cancer while preserving function of the treatment site. Such sites include head and neck cancers, breast cancer, and rectal or anal cancer. Dr. Cerrone graduated from Albany Medical College and completed his residency in internal medicine at North Shore University Hospital, which was affiliated with Memorial Sloan Kettering Cancer Center. During his training, he spent much of his time at Memorial Sloan Kettering Cancer Center, where he first learned to take care of cancer patients. He later trained in the radiation oncology program at Downstate University Hospital in Brooklyn, and subsequently became an attending physician at Long Island College Hospital in Brooklyn. Dr. Cerrone?
Thank you for that. And for the invitation to be here today. Thank you for the warm words. I'm really excited to be here today and talk to anybody about prostate cancer, recent updates, and then we'll finish up with talking about precision Cyberknife. Next slide. So it's a general talk, and we're going to talk about some new screening, how we diagnose the cancer, some general treatment options, and then I'm going to finish up with Cyberknife radiosurgery. So this is an older slide, how screening was first, has been implemented for many years. And you see with the American Urologic Association, patients average risk at 40 years old. Cancer Society started about 50 years old. But the U.S. Preventive Service Task Force, was not really high on any of the screening. But for a long time, we used 50 years old screening, and that's changed over the past few years. The urologists are more aggressive with the screening process, but with the recent information, that's changed. So we can go to the next slide. We can see that the U.S. Preventive Task Force, currently recommends stage screening in patients 55 to 69 years, and they give this a grade of C, where they give mammograms and colonoscopies A's for that screening process. So it's really because there may only be a minimal benefit to the screening in this age population. And you see that down on the bottom with patients 70 years old, it's really against treating with a grade of D. The urologists, have little bit different view, and they grade a B for the 55 to 69 and the C to 70s. The main thing is that in these patient populations that it's a shared decision between the doctor and the patient to undergo to screening to see what can be done. So we'll go to the next slide. The goal of screening is not only to identify cancer, but identify cancer that's going to benefit treatment, will benefit the patients. But studies have showed that with the 55 to 69-year-old age, about only benefits 1.5 deaths, 1.3 patient deaths over 1,000 men over 13 years. So, and then preventing metastatic disease in only 3 cases in this 1,000 patients. So you can see in this age population, it's very minimal. And then on the last sentence, it shows that the benefit of radiation screening is minimal above 70 years old. So that's one of the reasons why there's this grade of C, in this recommendation. So we can go to the next slide. And one of the reasons is that with only a minimal survival benefit, with any of the treatment options, patients can have erectile dysfunction, urinary incontinence, bowel issues, and that can happen in 2 in 5 patients depending on the treatment options, whether it's surgery and/or radiation therapy. And the same goes above patients who are 70, where they can have other side effects, with even less of a benefit, in these patients. So we can go to the next slide. And what's aside from the PSA, what is screening? And more recently, an MRI has been helping us to decide whether there's an abnormality in the prostate and whether the prostate can be done. These new MRIs can be done with a fusion biopsy and biopsying the area exactly where the disease. Still, the urologist will biopsy other parts of the gland to see if there's any disease there anyway. This can be done. There is an issue with the MRIs. A lot of insurance companies won't pay for it, but sometimes it can be done, and it is helpful in deciding how to proceed with a biopsy or not. We can go to the next slide. The MRI also helps with the treatment planning in some instances, but genetic testing is important for prostate cancer. It's not as important as it is in breast cancer because there's a small percentage, about 5 to 10% of prostate cancers can have a family history. But if you have the family history, it can be about 60% increase in cancer incidence. There is a BRCA 1 and 2 related to the prostate cancer. We don't do, these tests very much in men's population. But with better genetic testing on the horizon, there are some new tests coming out, Oncotype, Prostavision, Polaris, and Decipher being used more and more. We can go to the next slide. This is another interesting test called the 4K score. It's a blood test, and it measures the kallikreins related to the PSA in the blood. And it really is informative to see if there is an aggressive tumor associated with the prostate cancer that is pending to be biopsied. So if it comes back with a low score, then they say maybe you won't have a high risk of having a treatable cancer, or treated cancer. So you may not have to have the biopsy. If you have an intermediate or high risk score, you may have a higher chance of having a higher risk cancer. So then you should have the biopsy. So all of these things we're using to decide, what to do after the screening and decide if we should have the treatment. Once this is done, we'll move to the next slide. And so once we have a diagnosis of cancer, we see the patient, we do a history and physical, we stage the patient, and we put them in a risk category. And this is using the patient's age, and we'll go over this in another slide or two. We'll look at the pathology, the Gleason score, and then we'll make the risk assessment to put them in a risk category and make a treatment determination from treatment options and determination from there. We can move on to the next slide. So the stage for prostate cancer is what we call a clinical staging. It's done by the digital rectal examination, and it's to see if you can feel something on the prostate exam. Over 80 to 90% now in the PSA era, we can't feel anything on the prostate exam. And then that's a T1. If we do feel a nodule, it's a T2. If we see that it's involving seminal vesicles outside the prostate gland, it's a T3. And if it's involving the rectum, or we think it's the bladder, it's going to be a T4. So earlier in the staging, a lot of the primary care doctors aren't doing PSAs because of what we discussed previously, that the minimal benefit and side effects of the treatment. So the urologists are doing the PSAs, and they're doing staging with the appropriate digital rectal exams. We can also, what that helps with the staging is most of the patients are getting MRIs. So we want to see, once the diagnosis is there, do they have lymph nodes or do they have any bone disease, which could be evaluated on MRI or a bone scan if needed. We can go to the next slide. Staging is important. It's using a standard T&M staging with the tumor size, whether the nodes are involved, and whether there's metastases. Currently, this says the 7th edition, but currently we're using an 8th edition, which does get the PSA and the grade group of the Gleason score involved with the staging. So it's important to use and to decide what the treatment options we have for our patients. You can go to the next slide. And this is just a little bit difference between the 7th and 8th editions with the staging. T2 was an A and B. Now it's no longer subclassified. The Gleason score is into a grade group where 3 and 3 is a 1, a 3 and a 4 is a 2, 4 and a 3 is a 3, and then we move up from there. We can go on to the next slide. The Gleason score is something that everybody asks about, and it's a histological evaluation of the cancer cells that they see under the microscope from the biopsy. And it was first reported from Dr. Gleason, who reported there's a major and a minor component. They each have a 1 through 5, and then they report as such. Generally, for cancer cells, you need a 3 to be to be cancer. So we'll see a 3, 4, and 5, and then you have a minor component of 3, 4, and 5. You add these up, and you get your score, and then you can get your grade group from there. And it helps whether you can see with the 3, it still looks like a 1, similar to the cancer cells, but as you get to a 4 and 5, it's totally disjointed and irregular, and this is a more aggressive cancer, and this is what makes it harder to treat when you have a higher Gleason score. So you can go to the next slide. So once we have the PSA, the Gleason score, the grade group, the patient's age, we use all of these into formulating a risk group, and that's on the left-hand side of the table. We do use NCCN Guidelines. That's a National Comprehensive Cancer Network. It has a site that has every cancer documented. It has every cancer stage, and it's updated once or twice a year by physicians all over the country to give the correct treatment to patients with each stage of disease, and has options and what we should be doing. So specifically for prostate cancer, you can see on the left side there's very low risk, favorable, intermediate, and all of these have specific imaging guidelines, and then molecular testing, germline testing, and then on the right side it has the initial therapy, which we go on to the next slide from there. And you can see this is just an example of one of these slides where it says favorable intermediate risk group, and then it gives the treatment options for patients who have a long, greater than 10-year lifespan, or if you're, 85, in less than 10 years, it has options for these patients also. And then we use this, and sometimes it's good to show the patient this as you're explaining, where they're at along with the treatment options, and it can be helpful with this procedure. So we can go to the next slide. Once we get this and we go from there, then as a radiation oncologist, we talk about the treatment options. And this is a table that has just changed over 4 months ago, where initially you can see with the grade groups are very low grip, favorable, intermediate, and then it has a check mark, which is where you're allowed to offer the specific radiation types. But for the unfavorable and high barrier groups, we weren't able to offer the Cyberknife or ultra high fractionation, but now you can see the check marks in these groups. So we can offer it by recent data that shows that it can be beneficial or as good as the previous treatments. And so with this, we can see that the moderate hypofractionated is generally preferred in these grade groups, and whether we need to add hormones or not is important. But conventional fractionation is what we used for many years when we had a 9-week course. Hypofractionated group is anywhere from 4 to 6-week course, and the ultra hypofractionated group is Cyberknife, where it's 5 treatments. You see the other fractionation, the other checks below, brachytherapy of seeds, and we'll get that explanation in a little bit. So we can move on to the next slide. And so I just wanted to explain there's a lot of new trials that have come up with prostate cancer, and this is one of the more interesting ones. It was called the Prostate trial. It was reported in New England Journal of Medicine 2016. It compared active monitoring, radical prostatectomy, and radiation therapy. There were 82,000 patients evaluated. Only 2,664 patients were detected with prostate cancer, and 1,643 agreed to the trial. So this was, and they had 10-year follow-up group. So with there were double the cancer deaths in the active monitoring group, 8 versus 5 and 4. 8 is still a relatively low number for all these patients, which were equally distributed between these, but it was double compared to the radical prostatectomy or radiation therapy groups. Metastatic disease also was seen double, with 33% versus 13 and 16 in the radiation and radical prostatectomy. So, and then progression of disease was also double in the active monitoring versus the radical prostatectomy. So, although the active monitoring was double in cancer deaths, metastatic disease, and progression of disease, it was still a relatively low number. And we can go to the next slide. And the interesting thing is that with the cancer-specific survival at 10 years, there was no difference in the active monitoring, the radiotherapy, or surgery groups. That's shown on the graph on the top slide. Very, very similar. And then on the bottom is freedom from disease progression, where you see that with active monitoring is the only difference, where there was a higher percentage of failure in disease, whether it was local or distantly. And then the other thing that I take away from this graph is that the radiation arms and the surgery arms were exactly right over each other. So it showed that these results, that these treatments are equivalent for treating our prostate patients. So I thought this was a good trial. It showed that active monitoring, though it had double the amount of incidences with recurrences, it still had, the patients had very good survivals over 10 years, and there was no difference between the radiation and the prostate and prostatectomy in these groups. So we can move to the next slide. And so, what are your basic treatment options for prostate cancer? So we touched a little bit, and I'm going to go a little bit more into watch-rate and observation, hormonal therapy, surgery, radiation options, including brachytherapy. I'm not going to talk about cryosurgery or high-frequency ablation. So we can go to the next slide. And everyone thinks active monitoring is the same as surveillance or watch and waiting, but it's really not. Active surveillance is a specific protocol where you go under, where you check the PSA every 6 months. You can have digital rectal examinations, and you may have to have biopsy before. And if something changes, you go on to treatment. But observational watchful waiting there's no specific protocol for this. You don't have to have specific monitoring, and you only decide to do something if there's symptoms or if there's anything to go on. So usually observational watchful waiting is more for the older population. The active surveillance is being used more with low risk and our younger populations at this time. We can move on. Hormone therapy is interesting in that it's generally used for metastatic disease, and it's also used in conjunction with radiation therapy in intermediate or high risk disease. It's not generally used by itself unless they have metastatic disease. It has its own, and it's not what we call tumoricidal, where the cancer cells are not killed with the hormone therapy. It just suppresses them for some time. And then sometimes if you have metastases, you're on hormone therapy, it selects out some bad cells, and then after about 1.5 years or 2 years, you may have to go on to the next treatment. It does have its own side effect profile where you can have anemia, bone loss, loss of libido, erectile dysfunction, gynecomastia, hot flashes, and also can have cardiac issues. So we used to give it out more, but we're more judicious with giving it out now. And again, it's used many metastatic disease or with conjunction with high-risk disease. So we can move on. This is just an example of a typical Da Vinci machine that's used for the most common surgery this time, which is robotic surgery. It's still an excellent treatment for many patients. It's generally used in patients who are 65 years and younger, although if you're in a good performance status and excellent health, they'll do it in the early 70s. So it's still good. It does have its own side effect profile where you can have a little bit more incontinence, and they do a nerve sparing procedure, so the erectile dysfunction should come back in most patients. So still very good treatment for younger patients, and it's still used. There's still open prostatectomy, which can be performed in certain patients and still has its own side effect profile, but a little bit worse than the robotic surgery. Still really a good treatment option for many patients. You can go on. So this is brachytherapy, where it's either a one-time procedure for low-risk disease or used in conjunction with external radiation for higher-risk disease. We did a fair number of these at Mount Hospital, but about 5 years ago, a urologist left the hospital to go with a different group, and it kind of went out of our hands. And there are places that still do brachytherapy, and it's still a really nice procedure. You give a high dose of these specific radioactive seeds in the prostate gland, so the radiation is given from inside outside, and the patient is radioactive for can be a month or two, so you got to be careful around young children and pregnant females. But it's still really a good procedure. It's done. We don't do it here. There are physicians in Nassau who do it very well, and in New York City. So still one-day procedure, really nice treatment, can be done, readily. But it's a little bit out of favor because the external radiation options and the Cyberknife are better options we didn't have a number of years ago. We can move on. So just about the radiation therapy options, we had what we call 2D, low doses, high side effects, not very good control, and that's only been getting better as we did the 3D, IRMT, IGRT, SBRT, is Cyberknife, and then proton treatments I'll just touch on for a second. So we can move on. And this is an example of a standard new similar true beam linear accelerator. It has cone beam CAT scanners that we can on the side of the machine that we can image the patient during the treatment and make sure we're really right onto the prostate and that's why we can give such close margins and give a really nice treatment. So we can go on to the next treatment. Next slide. And this is an example of a proton therapy machine. There's only 2 locally. There's one on the Upper East Side of Manhattan, and there's one in New Jersey. And you know, the proton is significantly more expensive than any of the SBR or SBRT or IGRT options. And they say there's a little less side effects, particularly to rectal injury, but we don't see a lot with our treatment, so I don't know how it's that much less, and the cost is 5 or 10 times more. So it is an option for some patients, but I don't know if it's specifically that much better for prostate cancer. So we can move on. And this is just an example of an IMRT field versus a proton field. You can see that the red areas where the high dose is, and it's really very similar for both of these areas. The integral dose, or the green area, is a little bit more in the IMRT, and is doses that doesn't cause any real issues. So that's what they say is better with the proton, but the treatments have very similar efficacy and very similar side effect profile. We can move on. So moving on to the Precision Cyberknife, this is our unit in our office in East Setauket. It's a state-of-the-art unit. You can see the head is the linear accelerator, and the body itself is the standard robot, which can spot wells things on any assembly line. So it's all computerized, and it's really a great machine. We can move on. So why radiosurgery? Highly performed non-surgical treatments. Everyone says Cyberknife, is it surgery? No, it's non-surgical treatment, highly precise treatment. And the great thing about it is we can treat things in the brain, spine, lung, pancreas, liver, and prostate, any area, bone metastases, any area in the body. If you heard about the Gamma Knife, that only treats the brain area. So we can move on. And this is just an example of treatment of a cavernous sinus meningioma. You know, in the brain area, all of these pencil thin beams are beams that can shape the treatment dose, and it's very tight that we can make around the area with no margin. Then we have to be cognizant of the tissue around it to minimize the dose to the spinal, to the optic nerve, to the optic chiasm, so we can give a high dose of the tumor and minimal dose around it. We can move on. So how we give the treatment is that we can track the treatment real time during the treatment. There's x-rays machines on the top of the ceiling, and we can either track the brain, the spine, the respiratory tracking, and with fiducial markers. So patients are getting monitored during the treatment, and actively when the beam is on. So that's how we can give exactly a very tight field. We can move on, and it is frameless, even though for brain treatments we use a mask, but it's unlike the Gamma Knife, which screws into a really immobilization device. But this is just a frame, just the patient's not moving their head. It's a lot easier and more comfortable. We can move on. So specifically for prostate cancer, when we decide that we're going to give a treatment, the patient has to have fiducial markers placed in the prostate. Our urologist will do that. It's only 4 gold seeds that'll be in. That's 2 needles that come in from the perineum, and we can see that on the X-ray here. Once this is done, we let them sit for a week, and then we can go on to the next slide. And you can see that right here on the CAT scan with the markers in the center of the field. We'll move on. And once the patient's ready, we bring them in for simulation. The simulation is with the full bladder and empty rectum, as the empty rectum is also given during the treatment. And we do a vacuum back immobilization device that the patient is in the same position with his legs and bottom throughout the treatment and planning session. We can move on. Once we do the simulation, we do generally use an MRI to help assist the CAT scan in defining the exact location of the prostate. And then this helps us, again, be very specific on where the prostate can be. So we can move on. And this is just an example. Once we have the CAT scan, the physician draws the prostate out for the physicist to do the calculations. It takes them a few days to do this, and you can see once we draw it out, and these lines around the prostate are the doses. The white dose is the 100% dose, which goes right around it, and we can see it's a very tight area around the prostate gland. And in the upper left-hand corner, we can see all those pencil thin beams used to give this dose right around the prostate gland. Next slide. So with any of the cancer treatments, and specifically Cyberknife, there are side effects, and the side effects, can include constipation, incontinence, urinary retention, blood in the stool or proctitis, injury to the rectal bladder wall, and erectile dysfunction. Overall, we've been doing the Cyberknife treatment in our patients for 6 years now, almost 6 years come next November, and we've very low risk overall with any of these things. I have to tell you them, and I tell the patients that, but there's a very low risk. Most of the time, there's a little urinary frequency and some urge, happens a week or two after the treatment, and then it's much, much better. So we can move on. So I just wanted to explain, is there good results with the Cyberknife? And the answer to that is yes. Much of the information, Cyberknife comes from Winthrop Hospital, where they were the first one really in the world to do as many patients as anybody. And so they published this in 2014, 324 low-risk patients, 153 intermediate-risk patients, and they followed these patients for 6 years, or 7 years. And you see 7-year biochemical disease-free survival in low-risk patients, 96%. That's as good as any surgery, protocol. Intermediate risk, same thing, 90%, very good results. Unfavorable intermediate risk down to 80%, also really pretty good results. As the risk goes up, then the results are going to go down a little bit, but still 80%, 7 years is really good. The doses are conventional, and the PSA goes down very low. People PSA 5, 6, 7, median PSA was less than 0.1. So that may take a year or two to get down there. And then overall, the late grade toxicity, 1.7%, and 0% for GI toxicity. So tolerated well, very good results, and that's why this has been more popular, over the past few years. And we can move on. So this is our Cyberknife staff, and really we've been pretty stable for the past 7 years. Our nurse was floated in and out, but we really have the same guys. We're fortunate to have our physicist, who's Ken, on the right-hand side. He has a lot of experience, and we really just have a great team. We can go to the next slide. And this is the initial flyer, and on the left is Dr. Silverstein. We also have 2 other doctors in Cyberknife office, Dr. Yoon and Dr. Jane, who are helping us treat these patients. Next slide. And that's the end of my presentation.
Thank you, Dr. Cerrone, for your extremely informative presentation. If anyone has any questions, you may enter them in the Q&A feature on the bottom of your screen. We have no questions. I'll give it another minute. We have no questions. If anybody is interested in posing a question that we can have Dr. Cerrone answer for you, you can email us at matherhospital@northwell.edu, and we'll reach out to Dr. Cerrone and get you an answer. I want to thank everyone for participating and joining us today. We appreciate you. And once you exit the webinar, you're going to see a link to complete a survey. If you could please complete the brief survey, your feedback is extremely important to us. Thank you, Dr. Cerrone.
Very welcome. Have a great day.
Thanks.